Hey guys, can you see me? Can you hear me? Hello. Okay. Very good evening, guys. Can you see me? Can you hear me? Good evening, Ankita. Good evening, Sokata. So hope I'm audible and visible. So let's start. So we're going to continue the RRR series. Yesterday I didn't have a class because it is a bit of a hectic between the Nishchay batch and the RRR. So whenever days when I have the Nishchay batch, I might not have the RRR. And also whenever Dr. Santosh is taking the read with Harrison series with Santosh, I may not have it. Fine. Okay, so let's start. So, did you guys read about hyperplasia, hypertrophy, metaplasia, atrophy? Any doubts in that? Let's clarify that for first few minutes and then let's go to the next. Hello, Muzaffar. Hello, Kumar. Good evening. Good evening, Siddhartha. Any doubts in cellular adaptation? If there are no doubts, then let's go to cell injury. There are only two possibilities of no doubts. Either you understood everything or you didn't understand anything. I hope you understood everything. So we don't have much of a problem, much of trouble. Let's go to cell injury chapter. Fine. So the cell injury, the first premise of cell injury is why a cell should get injured. If adaptation can take care of everything, the cell should adapt, should come back to normal. Should adapt, should come back to normal, right? So the first reason is why should I have a cell injury, right? So there are two possibilities for a cell injury. I have a completely normal cell. This cell has an extremely high amount of a very high degree of an insult, right? Or a very severe damage. When there is a severe damage, a cell cannot adapt, right? Obviously, cell will automatically undergo injury. The injury can be reversible, injury can be irreversible, which might lead to necrosis. Or on the other hand, I do have a very mild stimuli, but the stimuli is very chronic. It's happening for months, years together. I'm not able to stop the stimuli. Let's say I'm putting just a tiny drop of very diluted acid also on my skin daily every day for the next 1 year, definitely skin will be damaged. My skin cannot adapt that, so that also will result in injury, right? So whatever it may be, any type of stimuli, it could be in heat, it could be physical, it could be chemical, it could be radiation, anything when it's severe, I will have an injury. And if it's mild and chronic, I'll have an injury. In both these instances, your cellular adaptation fails. Okay, only when the cellular adaptation fails, you will end up in having a cell injury or cell damage, right? So there's a premise of cell injury. And the prototype of cell injury for every cell in my body is hypoxia. We look at hypoxia only as a prototype for almost every cell injury from head to foot, right? And we look at hypoxia as a prototype and we'll explain how a cell from normal will undergo reversible as well as an irreversible cell injury of necrosis, because hypoxia is physiological or pathological. Can anyone tell me that? Let's keep it more interactive and not monotonous me alone talking. What do you happen? Hypoxia is physiological or pathological? Hypoxia is definitely pathological, right? Hypoxia is nothing but less amount of oxygen supply, which has to be pathological, which cannot be normal or physiological, right? I can have it as a hypoxia, or we can use the term ischemia. Both ischemia and hypoxia are pathological, so obviously it will lead to a pathological type of cell death, which is necrosis. Fine. Okay, so let's see. So again, I want you guys to be more interactive. Ask any doubt what you have. Let's keep on discussing more things, because that will help us to become solve your doubts. That's the only purpose of having a live lecture here, right? Don't inhibit any doubt what you have. Let's go ahead. Great. Lith is Tendulkar. Okay, fine. Pathological. Great. Let's start. So I have a very tiny simple cell where I'm having less oxygen supply, or it's hypoxia, right? When the oxygen supply is less, do you think aerobic glycolysis can happen? Can it happen or it will not happen? It cannot happen, right? If aerobic glycolysis does not happen, what glycolysis will it change to? It will obviously change to anaerobic glycolysis, right? So what is the end product of anaerobic glycolysis? Good evening, Abjit. The end product of anaerobic glycolysis is your lactic acid, right? Because of less oxygen, the aerobic glycolysis will automatically turn into anaerobic glycolysis, and anaerobic glycolysis end product is lactic acid. So this lactic acid or lactate, right, one and the same, will keep on accumulating. Okay, perfect, Prithvi. That is, it's accommodation, right? You must have definitely read that in your physiology itself. In high altitude, I'll have an accommodation where your heart rate, your everything changes, dynamics changes. So though I have less oxygen, my tissues will have good amount of oxygen and they will survive by default. When I say hypoxia pathologically, the tissues are not getting good amount of oxygen. That's what I meant. Fine. Okay, great. So lactic acid or lactate in long term, can I say this acid itself can cause cell damage because this is happening inside the cell? Anaerobic glycolysis happens inside the cell, right? This itself will definitely destroy proteins. It will definitely destroy proteins. So that is first in cell what's happening to me. When the protein is lost in any cell, right? Let's assume I have a liver cell, hepatocyte. The proteins are lost. Do you think they can do their function? They can't. I have muscle cell, right? Myocyte. Actin, myosin are lost. Do you think they can move? It cannot move, right? So when the protein is destroyed, by default the function alters, right? This will result in altered function by default. So it will alter the function, and this altered function is undoubtedly the first change which happens due to any injury. Any injury from head to foot, the first change before biopsy, before blood changes function. My heart is not having oxygen, heart will stop functioning. That's the first change. Same with CNS, same with the tip of the toe. Fine. Okay. Now a cell size might not decrease. Okay, great, Chinmay. Okay, cell size, we'll look at the cell size very soon, Saugata. Fine. So now second thing, when this cell is having hypoxia, that's reduced oxygen, what will happen to ATP production? Reduced or more? It will by default reduce, right? There'll be a reduction in the ATP production, right? So when the ATP production reduces, can I say that your sodium potassium ATPase will not work? It will not work, right? So this will result in less functioning of your sodium potassium ATPase, because then ion channel which is based on the ATP function, right, that will reduce. When the sodium potassium ATPase is not functioning, can I say the cell will have more and more sodium or the salt inside? The ionic imbalance or the homeostasis stops, right? So this will result in more amount of sodium inside the cell. So when I have more amount of sodium inside the cell, what will happen to water? Sogata, answer this question. What will happen to water? Will it be attracted inside or it will be pushed outside? The water will be attracted inside, right? So this will obviously will cause an influx of water. So when I'm having an influx of water, influx of H2O, what do you think will happen to the cell size? Will it increase or decrease? Perfect. The cell size will increase, right? So whenever I have a cell injury, the cell will swell. That's the first reversible sign of any cell injury from head to foot, right? This will result in cellular swelling. Okay, this can come in a Viva. This can come in an MCQ as well. Cellular swelling is the first light microscopic finding of cell injury. When I say light microscopy, it's a normal microscopy which you use in your hospital, right? You must have seen a microscopy in the path lab, physio lab. That's a normal light microscopy. The first change is cellular swelling. Cell will swell irrespective of which tissue it is. CNS, it will swell. Heart, it will swell. Liver, it will swell. Wherever I have cell damage, the first response is cell injury, cell swelling, right? So in other words, I have different names for this. I sometimes call it as spongy degeneration or a spongiform degeneration in CNS. The name is spongiform change. That's all. Same cell swelling. I call it a vacuolar degeneration or an hydropic degeneration in case of kidney. If it's in kidney, I use the term hydropic degeneration. Fine. Okay. Hello. Yakin neat. Okay. Next, I can call it an ballooning degeneration if it's in liver, right? So ultimately, cell swelling in different places, I have different terminologies. Remember this, any pathology you encounter in anywhere in the body, the first change is cell swelling, right? Like I said, okay, like I said, we'll look at the altered function also. Fine, let's discuss sometime else that about that side, my fine. So altered function will also happen. So when function alters, I'm just going to ask you a simple question. Tell me the answer. Let's discuss about it. I'm having a proximal convoluted tubule. What is the function of PCT? What do you think is the function of PCT? PCT's function is reabsorption, right? It's a very simple question. If PCT is not reabsorbing, do you think PCT will change microscopy wise or it will look the same? PCT's function is to reabsorb many things and push into the blood. Let's assume PCT is not functioning. Will it change in the appearance? It will not change. Reabsorption will be a problem. Symptoms might be there, but the microscopic appearance will not change, right? Let's take liver. What do you think is the function of liver? Liver's function is to metabolize and is to detoxify, right? Am I right in saying that liver metabolizes fat LDL, HDL, VLDL, everything? It is, right? So liver loses its function. Will the fat metabolism become abnormal? Is that statement right? It will become abnormal, right? It by default will become abnormal. When it becomes abnormal, can I say that I will have fat accumulation in the liver? We do, right? So functional alteration will not show in the microscopy. In the symptoms it might, but in few conditions like liver, you might see fatty change. I can see fatty change in the liver. That's a light microscopic change which is seen specific to liver. Right? Fatty change in liver can be seen in the microscopy, and almost every organ will have the swelling or the ballooning or the vacuolar degeneration, right? Now this is in light microscopy, right? Have you heard about electron microscopy? You must have. More magnification or less magnification? Undoubtedly more. Can I say I can see all the cell organelles like mitochondria, Golgi apparatus, peroxisomes in electron microscopy? Yes or no? We can see. In a light microscopy, we obviously cannot see them, right? So now there are few changes which is seen in electron microscopy. We'll look at them. I am reading EM for electron microscopy, fine? So I had a very simple tiny cell. Water had an influx of H2O. The cell became big, right? When the cell became big, there is a structure in the cell which will be like this, and also it has tiny dots on the top. What is the structure? Can anyone tell that? The function of this is to help in protein synthesis. The dots are the one which helps in protein synthesis. Rough endoplasmic reticulum, right? So when water comes into the cell, will the endoplasmic reticulum also dilate? It will dilate, right? So this also will result in dilatation of endoplasmic reticulum. When endoplasmic reticulum dilates, when the rough endoplasmic reticulum dilates, my ribosomes will be altered and my protein production still reduces. That also will happen, right? So here, not just endoplasmic reticulum, it will alter the mitochondria also. The mitochondria also will be damaged. When the mitochondria are damaged, in the electron microscopy, I have something called an amorphous densities. We look at what does amorphous density mean. Amorphous means no particular shape. That's what means amorphous. Density is black color. Anything black in electron microscopy, we call them an electron dense deposit. That's what we call as an amorphous densities. Fine. Now, if you look at this, can I say there's no particular shape for all these? Some are small, some are big, some are long, elongated. These are called as an amorphous densities or an amorphous densities in mitochondria, right? So this happens because the mitochondria is getting damaged. So in electron microscopy, it looks darker, more electron dense in appearance. We call it amorphous densities, right? Let's go back up once. Okay. Now, let's say more and more water enters. Can I say at some point of time it will burst? Is that statement right? It should burst, right? Before it bursts, is there a possibility I can see tiny blebs here? Is there a possibility that I can have tiny blebs? The areas which are weak will little bit swell more and then it will burst. That's how everything bursts, right? So this blebs, sometimes I might not be able to see in light microscopy, but I can see definitely in electron microscopy, right? I can see cellular blebs. Cellular blebs can be seen in electron microscopy. At the same time, I'll add one more question. We just discussed about proximal convoluted tubule, right? Brush border. If the PCT cell swells, what will happen to the brush border? Will it be maintained or distorted? Because brush borders are seen on the edges of PCT, right? It will be distorted, right? This cellular blebs will be there, and I'll have loss of microvilli or loss of brush border. And these are for particular cells. Brush border is not seen in every cell. Whichever cell has brush border, yes, it might be lost, it might be distorted by default, fine. Now, just listen to me carefully and answer this question. This area where the bleb is being formed, that particular area, can I say some amount of cell membrane damage has happened compared to this area where there's no bleb? Because one area has no bleb, other area has tiny bleb. Can I say that there's some amount of cell membrane damage? Yes, it has happened, right? So which means cell membrane is made of phospholipids, right? So can I say this area particularly will have phospholipids which are damaged, that's why it's becoming weaker. So that damaged phospholipids can be seen in electron microscopy as well. The phospholipids start accumulating, which is seen in electron microscopy as myelin figure. Okay, so this myelin figure looks like a whirl. It looks like this, black and white like a whirl. That's nothing but phospholipids at the site of the cell membrane damage accumulates and looks like this, right? Let's go back to the image and have a look. This is actually the myelin figure. The whirled appearance here is called as a myelin figure. Okay, the reason why it's called myelin figure is, what is myelin? What is myelin basically made of? You must have read in your biochemistry. What is myelin basically made of? Myelin is nothing but sphingomyelin. It's also phospholipid, right? So myelin normally looks like that in electron microscopy. So cell's phospholipid also, when it's coming outside of the phospholipid bilayer, it looks like a myelin. So we call it a myelin figure. That's all. Fine. Okay, let's go back. So these are the changes which I'll see in electron microscopy. I might not see in light microscopy. Not required for us for learning. For Viva, for an MCQ, it might come handy. Fine. These are reversible changes. Light microscopy, cell swelling, fatty change to compile. Blebs can be seen, blunting of villi, dilatation of ER, myelin figures, few nuclear alterations. Same, I can have few densities, few fibrillar elements can be lost, and also you have the amorphous densities. All these will be seen in case of your electron microscopy. Not very important, but it will be seen. Fine. I'll try my level best, Phoenix. More and more guys you participate and more questions you ask, I'll definitely answer. Right? See, that's what excites me. You ask more questions, let's become more interactive. I'll do it forever throughout the year. Fine. Okay. If you stop answering, I'll also stop. Okay. So now let's look at these two. Okay. So amorphous densities are due to damages in mitochondria, and myelin figures are due to damages in the cell membrane. Right. Okay. Now I'm just going to ask you a simple question. I want you to answer that. There's a normal cell. I had the bleb. Right. So I had the myelin figure and the amorphous density. When the cell, this cell, is it reversibly damaged or irreversibly damaged? What do you think? Reversible or irreversible? The cell with the bleb. It is reversible, because if ATP starts coming, sodium potassium ATPase will work, will push all the water and everything will come back to normal, right? It will, right? Perfect. Now let's assume that it becomes irreversible and the cell bursts. Okay, the entire cell bursts away, right? If the entire cell bursts away, can I say that time also I will have damaged phospholipids? Yes or no? This is an irreversible cell injury by default. When a cell membrane bursts, it has to be irreversible, right? I have reversible one, I have irreversible one. In an irreversible cell injury also, phospholipids are damaged, right? Am I right in saying that? Obviously, yes. So in an irreversible cell also, can I see myelin figure? I can see myelin figure, right? At the same time, in an irreversibly injured cell, can I see mitochondria also will be damaged? It's a dead cell. Mitochondria will be damaged, right? Can I see amorphous densities also? You can, right? So these two findings especially is seen in both reversibly injured cell and an irreversibly injured cell. That's a very common thing for reversible as well as irreversible surgery. Remember this forever. Again, this can come as an exception, can come in an MCQ, right? So how do I differentiate? If a question says small amorphous density, reversible, irreversible. The question is just saying small amorphous density, reversible, irreversible. Reversible, right? Very large flocculent amorphous density, reversible, irreversible. Irreversible, that's all. It's based on the quantity, right? If the question says the densities are small densities, I will think of an reversible injury. If the question says if it's a very large densities, I will think of an irreversible injury. Very high number of myelin figure, irreversible. Less myelin figure, reversible. It's a quantity which determines reversible or irreversible nature, right? So till now what we have learned is just the reversible cell injury part. Let's see what makes them irreversible, or in other words, necrosis, right? Let's go and have a quick look at it. For that, we have to learn about something called a point of no return. So let's say we had a normal, beautiful cell. This is a normal cell, and I have a cell membrane which is permeable, semi-permeable, impermeable. What is a normal cell membrane is? Normal cell membrane is perfect, undoubtedly semi-permeable, right? Which means it lets few of them inside, few of them it will not lead them inside, right? It's a semi-permeable membrane. That's how every plasma membrane or cell membrane is, right? It's semi-permeable, fine. Okay. Okay, now let's have a look what will happen when I have cell blebs. When I have cell blebs, you guys already accepted that at the area of the blebs I have a damage. Will it make them more permeable? Yes or no? Undoubtedly it will make them more and more and more permeable, right? So this will increase the permeability. Okay, this will increase the permeability, especially for one ion, which is calcium, because calcium generally stays outside, it will not come inside, right? So it will increase the calcium into the cell. Fine. Okay, bye bye Chennai, right? So more and more and more calcium comes into the cell. So when calcium comes into the cell, biggest problem of calcium is calcium will activate enzymes. Again, if you go back to biochemistry, you must have read about many of the enzyme activators, coenzymes, everything will be active. Many enzymes will be activated by calcium. If you look at your coagulation cascade, almost everything in coagulation cascade, calcium is an activator, right? This will activate enzymes. I am more concerned about three main enzymes. One is phospholipase. Once calcium enters inside, phospholipase will be activated, protease will be activated, and your nuclease will be activated. The reason why all the calcium is kept outside and very limited calcium is kept inside is this the reason. When calcium comes inside, it will activate all this. If calcium comes inside and activates phospholipase, do you think the cell can survive? It will burst. Already have a bleb, already is partly damaged. Automatically, it's going to burst, right? So we'll see what will happen when each of these are being activated. So first, phospholipase. Once the phospholipase is activated, obviously this will completely damage or rupture the cell membrane. Once it ruptures the cell membrane, can I say it's irreversible? It is. It will never ever come back to normal. It's completely irreversible, and is a hallmark finding of necrosis. In every necrosed tissue, the entire phospholipase will it will rupture and cause an irreversible cell damage. Right? That's first thing. Fine. Now let's look at protease. Okay. So you look at protease. Okay. So protease, as the name says, it's going to destroy protein, right? Entire cell is made of protein. Fine. So when I have cell, if you remember our previous class, I had told you that remember only three colors in H&E: blue, pink, and clear. What is the color for protein? Blue or pink or clear? The color for protein. By default, it is pink in color, right? So I have a cell which fully rich in protein and it's pink in color, right? Okay, it's pink in color. It's not blue, it's pink in color. Okay. Okay, it's a pink color protein, right? So now this pink color protein is being destroyed. Whenever you destroy any protein, it will result in precipitation. It will obviously precipitate, right? Gata, it's a very good thought process. Definitely, I can control necrosis if I prevent the entry of calcium. But when a cell membrane is weak, I cannot prevent the entry of calcium. It will by default come inside, right? That's the first thing. Second, necrosis will be seen even before the patient comes to me. Necrosis is a pathological injury, right? If I have a cell here not having blood supply, patient will not come to me because there's no symptom. Symptoms happens after cell death. That's the time they will come to us, and there'll be no way for me to stop calcium entry to stop necrosis. But that's a very good thought process. It can happen. Fine. Okay, let's come back to this. So protein will be precipitated. Anything which is precipitated will be lighter or darker. It will be darker, right? Anything in my body, when it precipitates, once it condenses, it has to be darker, right? This precipitated protein also will appear darker. In other words, your Robbins calls them intensely eosinophilic or an intense eosinophilia. Because the color is pink, it has to be intensely eosinophilic, right? This is by default happen in every cell injury, right? No, Samir, a protein when it's precipitated, it becomes darker. Yeah, if you have done an experiment in your biochemistry, you give heat to the 3/4 of test tube filled with urine, the protein becomes a coagulum. It will become darker. Normally, any protein when you destroy in the entire world, it will become darker. That's how it is. Protein destruction will make it darker. Milk protein, paneer, destroyed becomes darker. That's how it is always, fine. Kind of partial destruction paneer. Okay, perfect. So it will become intensely eosinophilic by default, right? Next, we'll take the third guy, nuclease. What does nucleus do? As the name says, nucleus will destroy nucleic acid. That's how it is. It will definitely destroy nucleic acid, right? Now, nucleic acid made DNA and RNA. I have a proper nucleus here. Okay, let's assume this is a functional nucleus. Every functional nucleus, will it be euchromatin or heterochromatin? If the nucleus is functional, a cell is functional, a nucleus is functional, U or hetero? It's a euchromatin, right? It's a true chromatin. A euchromatin will be open or closed. It has to be open, because only when it's open, your mRNA, transcription, translation, everything will form, right? So here, the euchromatin will be open. If the euchromatin is open, entire chromatin is open, it will be lighter or darker? It will be lighter. Generally, a functional nucleus will be light blue in color. Remember this again for a very, very long time, because we'll use the same thing in multiple places. A functional nucleus will be light. Lymphocyte, functional, non-functional? Phoenix, again a very good question. Okay, if I'm talking about hypocalcemia, that itself is a pathology, right? That time I don't worry about necrosis, because hypocalcemia can stop the heart. I have a bigger issue there than to worry about a cell death there, right? Okay, lymphocyte, functional nucleus, non-functional nucleus? The lymphocyte is functional, non-functional? Okay, I'll change the question. Lymphocytes gets activated to become dash cells. Have you heard about a cell in your physiology called as plasma cell? Have you heard about them? Or you're very young and not heard about them? Okay, lymphocyte is a non-functional nucleus. Lymphocyte matures to become plasma cell. So lymphocyte's nucleus will be very, very, very dark. Take any picture, lymphocyte will be dark in color, because lymphocyte is a non-functional cell. It will activate and become a plasma cell. That's the functional cell. Plasma cell will have light shade. That's how every body. If I have a cell which is not functioning, it will be dark in color, right? Have you heard about basal epithelium of epidermis? If you looked at the histology, the basal epidermis will always be dark, because that's how it will be. Because it's not functional, the only function is cell division. It's not creating any proteins. Any non-functioning, non-protein secreting thing will be darker. Anything which protein secreting will be lighter, right? Let's come back to this. A light blue functional nucleus. I'm adding nucleus to it. The nuclease enzyme is acting on it. It will break the nuclear strands. Functional, non-functional? It will become non-functional, right? So first thing, it becomes non-functional. It will become darker and become smaller. For the only reason I am breaking everything, it'll kind of crash into, it'll become smaller, right? This small, or in other word, I can call it a condensed nuclei. This I call it an pycnosis. It's called as a pycnotic nuclei or pycnosis. Fine, you can use any word. Okay, so this is the first change which happens in nucleus in necrosis. It's pycnosis. Even though it's non-functional, pycnotic, can I say still the nucleus has DNA, RNA? They do. It's not completely free of DNA, RNA, right? If still they have DNA, RNA, can I say nucleus can still act on it? It's a nucleus, right? Nucleus still keep on acting on it till I have the last ounce of DNA and RNA, right? So next what it will do is, nucleus will still break them. Once it still breaks them, I'll have fragments of it, right? So once I have the pycnotic nuclei, same the nucleus acts on it and makes them broken. So we call this an karyorrhexis. Rhexis is breaking, karyo is nucleus. You must have heard about karyotyping. I type the nucleus. Nucleus means karyo, right? Karyorrhexis. Fine. Even the broken strands of the nucleus will have nucleic acid, DNA, RNA. Nucleus will not stop it, right? Nucleus will still act on the broken strand. Finally, I'll have karyolysis, right? So now tell me, at the end of a dead tissue, a necrotic tissue, will there be any blue color or no blue color will be left, right? When there's karyolysis, by default, this cell is a dead necrotic cell. You will have no blue color. It will be only pink, and that too darker pink. If you have a darker pink tissue, no blue color, think of a necrotic tissue, right? There'll be no blue color because it's completely lost. Entire thing is completely lost. That's how a necrotic tissue will look like, right? Now let's talk a little bit more about necrosis to understand the outcome of necrosis. I had a completely normal cell here. Okay, this has kind of broken like this. the nucleus also was kind of fragmented and kind of lost. Fine. Now tell me, if the cell membrane breaks, will the intracellular contents come outside? Am I right in saying that? Yes. So the cell membrane breaks, the intracellular contents, whatever is there, will leak. Okay, will obviously leak. Fine. I'm just going to give you a random question. Let's see if you can answer that. Okay. In a patient's body, we took a blood test. The patient's body's creatine kinase was very, very high. Which cell has been affected? Very high creatine kinase. Which cell membrane do you think is burst? Creatine kinase? Can I say muscle? Because muscle is very rich in creatine kinase, right? Perfect. Not cardiac. I'm talking about muscle. Any straightened muscle have creatine kinase. Cardiac muscle have creatine kinase MB. That's a special fragment for in cardiac muscle, but any muscle cell. Perfect. I have a patient's blood test, and the blood test says that there's a very high elevation of SGOT, SGPT. Which cell is affected? Liver cell, right? So most of my biochemical test indirectly says that, okay, this person's liver or muscle, cardiac or a skeletal troponin, that particular organ is affected. Because it's not always possible for me to poke the liver, poke the muscle, poke the heart and look into the microscopy. So I have a surrogate evidence, right? So this is the way all the enzyme tests work. Every enzyme, most of the enzyme analysis basis is based on this. It'll rupture, all the contents come outside, right? Now let's take the same thing. All the intracellular contents come outside, right? So can this attract more inflammation? It can. So these intracellular contents, when they come outside, or we have one more term for them called as DAMPs. Okay, it's damage associated molecular patterns. When a cell is damaged, all the damage associated molecular patterns will come outside. Fine. All these, it's a damaged tissue. All these will attract inflammation, right? This will attract inflammation. Your inflammatory cells will come inside, and the purpose of the inflammatory cells is to remove or clear all the cell debris. It will automatically clear the area, clear the debris. That's how inflammation, entire necrosis will stop, right? Now I'm just going to ask you a question just to understand and to link to tomorrow's lecture. I'm having an inflammatory cell coming into a necrotic area, right? Will inflammation cause pain? Is that statement right? Will inflammation cause pain? Yes, no, maybe. Inflammation will cause pain, right? That's how every inflammation is, right? It will cause pain. So now tell me, is there any possibility a physiological cell death can be necrosis, or necrosis is always pathological only? Because every time when there's necrosis, I'll have inflammation. Every time when I have inflammation, I'll have pain. Can a physiological cell death be necrosis? It can never be necrosis, right? Because every inflammation will result in pain. Whenever there is pain, necrosis is almost always pathological. If it's physiological, it cannot be necrosis. That's why we have one more cell death called as an apoptosis, right? Necrosis is always pathological. That's how it is. I cannot have a physiological necrosis, fine? Next. So all this will clear the entire debris, fine? Then if the organ should be replaced, the stem cells will come and replace the organ, right? That's how necrosis ends, right? So this is the terminal thing in necrosis: phospholipase, protease and nuclease. Remember this, because tomorrow when we read about types of necrosis and apoptosis, we might relive the same thing. These things are very important for us on a long term to understand systemic pathology also, fine? Okay, now these are three images in Robbins. We'll end with this. Okay, there's an tubule of the kidney. Let's assume PCT. Can anyone tell me what are these? What are these? This is the tubular epithelium. What is there? Something seen on the top. Okay, Phoenix, read your comment once again. You'll know the answer. Apoptosis, cell death, right? If it's cell death, it cannot be reversible. That's all. Okay, so that I'll put in the Telegram group. It's the microvilli or the brush border, right? Perfect. Okay, there's a brush border or the microvilli, fine, of the proximal convoluted tubule. This is a completely normal cell, right? Now look at this area. the second image here. Can you see the brush border? It's not seen, it's disturbed, not exactly beautiful like the first image. It is not perfectly seen. At the same time, can you see the cell membrane? Can you see the nucleus? That is seen, right? So in the second image, is it normal, reversible cell injury or irreversible cell injury? I can't see the brush border, but I can see the cell membrane. I can see the nucleus. This is how it looks in a reversible cell injury. Fine. The reversible cell injury, I do have few changes, few alterations, but it's not exactly the same as the before, right? Next, look at this area. This also is a tubule, right? This also is a beautiful tubule. This area, are you seeing any nucleus? No nucleus. Look at this area. Any nucleus? Look at this area. Any nucleus? These cells. Any nucleus? Or any blue color? There's no blue color at all. When there's no blue color, there's no nucleus, which means it's a necrotic tissue, right? That's how necrosis looks like. We look at the types of necrosis in tomorrow's class. This is very, very important. I need to first identify what is a dead cell look like. Then it's very easy for us to look at the type of necrosis, understand the types of necrosis also, fine? So these are, and remember this, even though it's dead, can I still say it is looking like a tubule? Is that statement right? Kind of the shape is maintained. It's a dead tissue, but still you can see the lumen. It's a dead tissue. Still there's some amount of lumen maintained. We'll see why it is in tomorrow's class, fine? Okay, this is what happens in your normal thing, a reversible cell injury and an irreversible cell injury, fine? Okay, that's it for today. If there's any doubts, do let me know. If not, we'll call it a day. Okay. No doubts. We'll look at the types of necrosis tomorrow, and if possible, we'll touch base on a little bit about apoptosis as well. Right? Okay, great. See you guys tomorrow. Be here exactly at 9. I'll try to complete everything. Phoenix will complete apoptosis and you will answer the question yourself. You'll definitely answer the question yourself, Phoenix. I'm sure. Okay. Robbins, Sunny, I have the Robbins here. I'll definitely try to put it in the group, or let's see if I can pick up Robbins. Just give me a second. It might take some time. I have to go to the correct area. I'm not sure where it is. Sunny, these are the Robbins. Fine. Okay, we'll look at the table very soon. I hope it's visible. Fine. This is where your reversible cell injury comes. Okay. The early alterations, reversible cell injury, and all the changes which is there. The sodium potassium ATPase pump failure, the influx of water, later the mitochondrial damage, fatty change also can happen, especially in liver and not in many other tissues. Fine. Okay. Phoenix, I would say after the RRR, go back to Robbins and read this part alone, right? And all these places where you have the hydropic or the vacuolar degeneration and the ultrastructure. Ultrastructure stands for your electron microscopic changes and all these changes, right? Nuclear alterations, few changes might happen, not very important for nuclear alterations, but other things has been asked in MCQs previously. Just have a quick read at it, fine? Okay. And the cell death, so the reversible cell injury will be automatically followed by irreversible cell injury, right? So we have necrosis and apoptosis. We look at apoptosis very soon later. This is the image what we saw. Vineet, I'll tell you, I am also from a government school. When I completed my 12th standard, I was also not good in English. The only thing is time, right? Hindi is enough. Little bit understanding of English might be required. Don't worry, but because the books are in English, the articles are in English, right? Hopefully, there is some time in future where the entire article and book comes in our mother tongue, so we can have much more understanding. As of now, little bit, okay? Thoda, if you can try, you can definitely do it. Sure, Najresh, I will do it. Okay. So necrosis, if you look at necrosis, the entire process, it's will have in this place it'll have talk about dams, how the necrosis ends, right? Necrosis due to leakage of intracellular proteins to the damaged plasma membrane. that will have all the troponins, enzyme, alkaline phosphatase, transaminase, everything which comes in the just give me a second. All the outcomes of necrosis, that all will be here. And what are the morphological changes which happens in necrosis? Be it an increased eosinophilia, loss of cytoplasmic RNA and everything, myelin figures, the nuclear change of your karyolysis, pycnosis, and your karyorexis as well. Fine. Okay. Karyorexis. That all those things will be here. Patterns of necrosis, that's a different types of necrosis. We'll see it tomorrow. Okay. It's just there. It is an ebook version of 10th edition of Robbins, Pathology of Basis of Disease, 38, 39, 40 page number. Fine. You tell me, Vinit, क्या आपका समझ नहीं आती है? I'll try to explain slowly in English. मेरा हिंदी is not so good. मेरे दिमाग से हिंदी से flow नहीं आती है. So only I try to use English. Fine. Okay. Not at all, Vinith. See, if you can complete physics, chemistry, and biology, English and Hindi is not a problem. Fine. No, Dipesh. If it's necrotic, it's dead. That's all. Once it is dead, the only thing is I can create new cell. New cell will come and replace it, but old cell is gone. That's all. Necrosis, cell death, it is irreversible. Fine. Okay. See you guys tomorrow. Great talking to you guys. Bye bye.